pleasure to introduce one of our pediatric sports medicine colleagues from University of Colorado Orthopedics and Children's Hospital. Emily Stewart is with us, and she's going to give us a talk on how to approach the pediatric knee injury. And I think this is really worthwhile because the kids' knees aren't quite the same as the adults. So go ahead and get your seats, and we're going to have Emily come on up and give her take on the pediatric knee.
All right, thanks guys. So like he said, I'm Dr. Stewart. I'm at Children's. I have no conflicts of interest, but I do love gymnastics, so you can't get a talk from me without gymnastics pictures, so that will be in there. So we're just going to talk briefly about the anatomical differences in the pediatric knee, and then how I approach a pediatric patient who has a pediatric knee injury or pediatric knee pathology. So we have a saying in pediatrics that children are not little adults. Their physes or growth plates are open, and those are weaker. They often lack flexibility, especially when they're going through their growth spurt. If you've ever checked teenage boys' hamstrings, you will find they don't move very much. And then they often have really bad mechanics as well as they're getting their new body. If I could put pretty much every adolescent in physical therapy for 6 weeks, I would, because they just don't know what to do with their arms and legs. And so we treat these kids a little bit differently than the adults. And so if I have a little gymnast like this versus an adolescent versus a college gymnast, I'm going to treat them quite differently. So we already had a talk on pediatric knee anatomy in general, so I'm not going to delve into that too much with my limited time. And we also talked previously about history and exam, but a couple things I want to touch on. So in the history for a pediatric knee, you're going to want to know, is it an acute injury or was this just insidious onset? What was their exact mechanism? A lot of times the kids cannot tell you. They're like, I don't know, I fell. And then could they walk afterwards? Where exactly did they hurt? That one finger pointing is really helpful unless they do, it hurts here. So I try to really pinpoint where exactly it hurts. And then do they have any mechanical symptoms? For the exam, start with an inspection. It's really important in pediatric knees to know if they have an effusion or not, because that often changes your management. Going through palpation, range of motion, strength, special tests, and then looking at their mechanics as well, and always comparing side to side. You don't have to go in this exact order, but you want to have a pattern that you do pretty much every time that's systematic so you don't forget things. Typically getting x-rays is important in pediatric knees. We usually will get 4 views. So this is an AP, your lateral, your tunnel view, and your sunrise. And just noting on that AP view, so if you want to, I don't know if I can go backwards, kind of. Their growth plate in their femur, their tibia, and their fibula, important to point out. The tunnel view I usually don't get unless they're 10 or older. So you're looking for an OCD typically in the tunnel view, but if you get an 8-year-old's tunnel view, you're probably gonna see all this irregularity and think, oh gosh, there's these giant OCD lesions there. It's just because they're so skeletally immature and have a lot of cartilage that you are seeing what you think may be an OCD. And then your sunrise view is really nice for patellar tracking. So insidious onset knee issues. I'm not going to talk about every type, but just kind of touch on a couple that are unique in pediatrics. So osteochondritis dissecans, typically an overuse injury, but they may present with an acute injury, and then you'll find the OCD there. This is injury to the subchondral bone in the cartilage. Most of the time, it is on the lateral aspect of the medial femoral condyle. That's about 70 to 80% of the time. So that leaves 20 to 30% where there are other places. So you're going to want to make sure you're checking the lateral femoral condyle as well as the patella, because you can see OCDs there as well. You're going to want to get those x-rays, the tunnel view most importantly, and then sometimes that sunrise view will pick it up as well. And then you're going to want to get an MRI to stage this lesion or to determine if it is a stable lesion versus an unstable lesion, because that will change your management. In kids, unlike in adults, kids whose growth plates are open have really good healing potential if they're treated appropriately. So that's why it's really important to get that MRI, because you usually can treat them conservatively if it's a stable lesion. It takes a long time for these to heal. Typically 6 weeks immobilized, then 6 weeks in PT with protected weight bearing, and then going back into sports. So it can take 3 to 6 months to get them back. This is an example of a lateral femoral condyle OCD. So you can see kind of that moth-eaten looking appearance or cystic appearance of the lateral femoral condyle. And then just a couple other MRI images. So one on the femoral condyle and then one on a patella. Patellofemoral Syndrome. This presents as anterior knee pain. I'm sure everyone has seen someone with this. Usually the pain is with repeated knee flexion, like squatting or kneeling down. They may complain of some crepitus, and so it's really important in kids to differentiate, is your knee popping or is it catching locking? Because they may have some popping, and that may fool you into thinking, oh, maybe they have a meniscal tear. The patellar grind test or compression test may be positive, where you press down on the patella and have them activate their quad. That forces the patella down into the femur. If they have a mechanical problem, like they have increased genu valgum, they pronate a lot, or they have external tibial torsion, they're more at risk for patellofemoral syndrome. And also, if they have really weak adductors and external rotators, they're definitely at increased risk, which again, in our adolescents, we see that a lot. Your x-rays may be normal, or they may have a little bit of lateral patellar tilt. You're gonna wanna treat this with physical therapy, activity modification. Sometimes a brace like a knee sleeve can help, or a patellar stabilizing brace, if they have a lot of mobility, can also help. And then apophysitis, this is kind of bread and butter for pediatrics. So apophysitis of the patella, or of the tibial tubercle, is called Osgood-Schlatter's. It's due to repeated traction at the tibial tubercle. Usually these kids will come in insidious onset, they're tender right there. If you ask if their knee gets swollen, they'll say yes, but it's usually just focal on the tibial tubercle. And they'll have pain with resisted knee extension. You just do lots and lots of stretching and then working on their mechanics. And you can also do a Chopat strap or patellar tendon strap to help with that. You're gonna wanna be aware of a tibial tubercle avulsion fracture, which I'm gonna talk about fractures at the end. So we'll talk, remember to not forget that in this one. And then apophysitis is the inferior pole of the patella is Sinding Larson Johansson. These kids present a little bit younger, whereas in Osgood, it's usually 11 to 15. These kids may be like 9 to 13, so a little bit younger. They may have some irregularity there. And again, resisted knee extension may be painful. And you're gonna wanna not miss that patellar sleeve avulsion. So if they can't straight leg raise in either case, Osgood or Sinding Larson, you're gonna wanna do further investigation. Okay, moving on to acute injuries. So ACL tear, I'm not gonna talk much about. They present similar to kids or to adults. You want to reconstruct these. It seems that delaying reconstruction leads to worse outcomes. And I'm not a surgeon. All epiphyseal reconstruction on the most recent review paper I read was the best one. So I think Dr. McCarty's gonna talk about that. All right, fractures. This was actually one of my high school kids. I didn't see him in clinic. He was doing a box jump and did that. So the Salter-Harris classification is really important to know. This is, again, kind of basic for pediatrics, but Salter-Harris 1 is right at the growth plate. So these may look very normal on x-ray, but it's a clinical diagnosis often that they hurt right over that physis. If that's the case, you're gonna be suspicious for a fracture. Salter-Harris 2 goes into the metaphysis. Salter-Harris 3 goes down into the epiphysis. 4 goes up and down into the epiphysis and metaphysis. And 5 is a crush injury. It's pretty rare. 3 and 4 you're gonna really need to make sure you're keeping an eye on, because that does involve the joint space and can cause problems. So this is probably really dark. I couldn't figure out how to make it lighter. But this is a Salter-Harris 2 of the distal femur. I don't know if you guys can, oh, that's the wrong one. See that little line right through there? Distal femur fractures are about 5% of all growth plate injuries. Typically an AP and a lateral is all you'll need to see this. However, sometimes we don't see fractures in kids, and so if you're suspicious, you may need to get an MRI. If they're not displaced, you can cast them, but you do need to monitor for growth arrest in all pediatric fractures. The distal femur accounts for 40% of your growth in your leg, and so if that growth plate shuts down, they're gonna have some growth discrepancy. This is another one that the x-ray looks totally normal, but on the MRI you can see a little line right here and then a lot of swelling in the knee. So again, don't miss it just because you don't see it on x-ray. And then proximal tibia fractures, pretty uncommon, less than 1% of pediatric fractures. May see this on your x-rays, and then again, if you're suspicious, get your MRI. If it's a Salter-Harris 3 or 4, you're going to want to get that CT to look for displacement, because if there's more than about 2 millimeters of displacement, they may need surgery. Otherwise, you can cast them. And again, monitoring for growth disturbance, so looking for those Park-Harris lines in about 6 months to a year, and making sure that growth plate's not shutting down. Tibial spine avulsion, so these may act like an ACL tear on their mechanism, but you're going to want to x-ray them in full extension if you can, because that's going to tell you if that fracture is reducing or not, and so that will determine if surgery is required. And then that tibial tubercle and patellar sleeve avulsion. So if they cannot straight leg raise, you're going to want to potentially MRI to look for displacement and chondral injury. If it's not fully or far displaced and in a week or two they can straight leg raise, you can mobilize them, then brace in physical therapy, and then progress in PT. So in summary, making sure you take that good history and exam, sometimes slowing down with your pediatric patients because they won't understand your terminology and need some more time. And then looking for any kind of mechanics, flexibility issues, especially with your insidious onset. And then monitoring their growth after a physeal fracture injury is going to be really important so that they don't have long-term issues. Some references, and that's it.